Hello, and welcome to Conversations in Interventional Cardiology. My name is Suzanne Baron. I'm a deputy editor at SCAI and the director of interventional cardiology research at Mass General Hospital. I am honored to represent SCAI and the SCAI's editor-in-chief, Dr. Alexandra Lansky. We're here today to discuss a very important document that was recently published in SCAI entitled The SCAI Position Statement on Intracardiac Echocardiography to Guide Structural Heart Disease Interventions. I'm lucky to be joined by an esteemed panel of SCAI leaders and experts, Dr. Mackram Eleid, professor of medicine and Department of Cardiovascular Medicine, a consultant at Mayo Clinic, Dr. Andrew Goldsweig, who's the director of cardiovascular clinical research at Bay State Medical Center, and Dr. Omar Khalique, who's the director of the Division of Cardiovascular Imaging at St. Francis Hospital and Heart Center in New York. So thank you all for joining, and I'll turn it over to Dr. Eleid to start the conversation.
Well, thank you for that great introduction, and it's really a pleasure to be here with this group to talk about the new SCAI position statement. And this really came from the rapid growth that we're experiencing in structural heart disease interventions. This is an unprecedented growth in the field. We're able to offer minimally invasive therapies to patients which were not available a decade ago. And this has been driven by device technology innovations, advances in imaging techniques, and then also the growing expertise of the heart team. And that's part of what this position statement is focusing on. And transesophageal echo has been instrumental in guiding a lot of the structural heart interventions and continues to be. But we're currently experiencing a growth in intracardiac echo, which is both driven by improvements in technology and also operator expertise. And that's really what this position statement is focusing on. And in this statement, we go over some of the advantages of ICE, intracardiac echo, and TEE. And now with ICE having 3D capability, it's becoming more and more like TEE in terms of having biplane and multiplanar reconstruction imaging available. In many cases, image quality is getting close to that of TEE. And then we're also seeing that, that we are able to use this for a growing number of procedures. And there are some situations where TEE may not be an option in patients with certain esophageal pathology where it becomes even more instrumental. But there's many different obstacles and challenges with ICE, particularly in crossing the atrial septum, having a lower number of imaging elements, and then TEE can have more acoustic shadowing due to cardiac rotation and other structures, particularly when we're looking at the right-sided structures. So there's definitely advantages and disadvantages of both of these modalities, both of them having good safety profiles. But we're kind of going over all of that in this position statement and then discussing how ICE also lends itself well to the two-physician model where an echocardiographer is controlling or creating the images and interventionalist is helping move the catheters. And there are 3D ICE systems that are currently available on the market, and these are the main ones. We have the AccuNav Volume, New Vision, and the VeriSight Pro, and each of them have some unique features, including different array configurations and then also different numbers of imaging elements, but all of them have 3D capability, biplane, multiplanar reconstruction imaging, and then each of them have some unique features such as digital 3D steering, for instance. And so this is something that is included in the position statement. And we also bring about the importance of having standardized views, similar to what we have with a TEE study, with an ICE study, discussing the concepts of what are the standardized views so that we begin in the home view and we have a certain order of procedures that we'll do for every case. If we're doing a transeptal puncture, ruling out an effusion at the beginning and the end of the case, and having a certain set of images that are specific to each procedure. For instance, if we're doing a mitral intervention, we would likely want to cross the atrial septum after doing the transeptal puncture. So these are all things that we review in this paper and discuss. We also talk about ICE expertise training levels. And this is a very basic concept where we're talking about the skills that are required to operate 2D ICE, which is often sufficient for transeptal puncture or simple ASD closures and PFO closures. And then the complexity increases when we go to left atrial appendage closure, where we have to integrate CT imaging and in some cases crossing the septum as well, and having a very precise crossing location in the septum. And then the mitral and tricuspid interventions having an even steeper learning curve from the standpoint of integrating ICE into the procedure, where we have more heavily rely on 3D technologies that have a very complex knobology. There's a big learning curve there. And also where that 2-operator model becomes even more important, so that the echocardiographer is operating the 3D ICE console, the interventionalist is manipulating the ICE probe. And then we propose a certain number of procedures for each of these to have the appropriate expertise. And it's also important to think about, how do we start an ICE program at an institution that's not already doing ICE, given that this is growing in importance, and we're seeing a lot of improvements in the ability to perform procedures in a shorter amount of time, or even do it in a more successful manner with both combining ICE and TEE. But it requires an understanding of the additive value of ICE, the benefits and advantages of ICE, guidance for structural interventions. So each institution has to look at the cost and the value, and then think about, how does implementing ICE affect the workflow, the scheduling of procedures, the finances. And currently reimbursement is only as an add-on CPT code billed by the interventionalist. So this is something that we point out as an area that needs to be improved, to really recognize everything that goes into the use of ICE. And then also the training of the team required for successful implementation, which we talked about in the previous slide. And this is the central illustration for the position paper that I think really nicely summarizes a lot of the key concepts that we talk about. So we have on the left-hand side all of the different procedures that can sometimes be done with standalone ICE only, and that also can be done oftentimes with 2D ICE only. And then as we move to the right, we oftentimes are increasing the demandingness of the imaging for the procedure. We have the mitral interventions, which are still heavily done with TEE guidance, but there's growing use as standalone or as an adjunct to TEE use of ICE. And then the tricuspid interventions, which are in a similar situation as mitral, where ICE is even more heavily used, and there's growing use of standalone ICE guidance for the tricuspid interventions. And similarly, on the left-hand side, the knobology is more straightforward. The expertise in the use is maybe less demanding of the imaging console, and then it becomes more complex on the right. And it really lends itself better to a multi-operator model, where you have a dedicated echocardiographer operating the console as we get to these complex interventions requiring 3D ICE. And then, of course, the concepts of reimbursement needing to be improved, minimum data sets as well needed to track the use of ICE, and then quality standards as well to ensure that we're using it in a consistent way and in a thorough way as well. So that's kind of a summary of what our position statement includes. And I'm glad to have Drs. Goldsweig and Khalique here, as they were heavily involved in this. And so we'll look forward to the discussion. Thank you.
Great. Well, thank you so much for that great presentation on what is definitively going to be an incredibly important document. I think I will open it up actually to Drs. Goldsweig and Dr. Khalique, as they are we're part of the writing group. I think I'll start with you, Andy. Tell me from your perspective, what have you learned about incorporating ICE into your practice, and how did that sort of inform your input on this document?
Sure. So thanks so much for the opportunity. And Mac, thanks for the great summary. I think ICE is an evolution. It's really a step toward the future of many aspects of the field, many aspects of the future of interventional cardiology. When we began each one of our procedures in interventional cardiology, say the beginning of it all, angioplasty, it was performed in an operating room with a surgeon standing by under general anesthesia with a plan for emergency bailout when the worst happened. The same thing was true in the early days of transcatheter aortic valve replacement. The very first cardiac surgery to use a heart-lung machine actually was an ASD repair, and certainly in the early days of septal intervention, those were performed again with full plans to open and rescue if needed. And we've seen all these procedures move forward and become minimally invasive. ICE is the next step in that regard. So the procedures we're performing today that are maximally invasive, that involve general anesthesia and transesophageal echocardiography, can become minimally invasive with ICE. I think if I can add to that, I don't sell ICE. Nobody pays me to sell ICE. But I do sell ICE in the fact that I need to sell it to the hospital as a way, when I work with my hospital leadership, to tell them that this is how we can make our department more productive clinically, more productive academically, and able to better serve our community. So, when I walk into the meeting of the leadership of the Heart and Vascular Center, ICE is something that, with intracardiac echocardiography, is something that lowers procedure time, causes rapid recovery, rapid room turnover, same-day discharge, more procedures in less time, and increases patient satisfaction. So when you walk in with that list, I think you can convince almost any audience that intracardiac echocardiography is the future of the field.
I think that's a really important point about, kind of how to justify the, kind of the economic challenges of bringing ICE to being a more widespread use across, some of the institutions, and certainly the document really does, cover a lot of that. Omar, I'll ask you, from your standpoint, how have you at your institution integrated ICE in conjunction with with echocardiography and the echocardiographers, getting them comfortable with kind of doing this as a joint procedure, as was discussed by Mac? How's that worked for you?
I think one important aspect is to create a workflow that everybody's gonna get on board with. So we have a published workflow, for example, for tricuspid TEER, which is in JACC imaging, with a very simple protocol switching between mid-esophageal and transgastric views for TE, and doing certain portions of the procedure with the 3D ICE catheter. So I think it's important to have a dedicated workflow, just as we're trying to standardize the views in this document. I think it's also important to have a dedicated workflow with ICE and TE if you're using it for each procedure. For LAO, which Andy is an expert in standalone LAO, in different hospitals in our system, we actually have different workflows based on what the operators are most comfortable with. So at the main center, actually, they're a little bit more hesitant to move away from TE towards ICE, whereas at one of our other hospitals, they're actually transitioning pretty quickly over to standalone ICE. So I think there is room for multiple models, and it's going to depend on the workflows and people's comfort levels as they get trained.
I think that's a great point about the importance of standardized views. I think we know that when we look at a transthoracic echo, that it's going to start with a parasternal long axis view and a parasternal short axis view. And then at some point, somebody's going to do a tip down to look at the tricuspid valve and probably move to the apex and do an apical 4-chamber, 3-chamber, 2-chamber, 5-chamber. There are 5 chambers. Yeah, there are 5 chambers. When you look at a TEE, you expect a mid-esophageal 4-chamber view. You expect somebody's going to show you a bicaval view. We can name all these views based on what we see. ICE, the catheter can be moved around the heart into so many positions. It's very difficult sometimes to tell what you're looking at. But as Max said, if we really harp on having standardized views and moving through standardized views in specific procedures and having terminology for standardized views, it becomes a lingua franca. It becomes the standard in the field, and we can all work together across institutions, across countries. If we start in the home view, and everybody knows the home view, you're in the right atrium looking at the tricuspid valve, and there's the right ventricle beyond it, and you see on the right side of your screen the aortic valve, and behind it the pulmonic valve, if you're lucky. Then you check for effusion by putting the catheter toward the right ventricle and looking toward the left ventricle. That you have 2 septal views, a septal long axis and a septal short axis. That you have 3 left atrial views of the left atrial appendage, an aortic valve view, a mitral valve view, and a pulmonic valve view, angulations looking at the appendage. So I think building this lingua franca of standardized views is a huge step forward to incorporating ICE throughout the field.
I think that brings up a really important point, though, that you're saying that you really do need to have kind of a standard set, standard views to start getting really comfortable with this. And one of the things you guys talk about in the position statement has to do with the learning curve. So I will openly admit to being a level 1 ICE operator. I can close the PFO, and I kind of know the few knobs there, but I'm certainly not a level 2 or a level 3. But let's just say I wanted to do that. I wanted to increase my ICE knowledge. Mac, I'll throw this one to you. What are the first 3 or 4 things that you would recommend, or that the consensus statement recommends that that I do to get myself up to speed to being an appropriate and an educated ICE user? We've already got one option, one suggestion, which is standardized views and understanding those views. But what would you add to that?
Yeah, that's a great point, Suzanne. I don't know where I fit on this either. I feel like I'm maybe off the screen and on the left or on the bottom somewhere. So this is just a very basic framework, but I think, as Andy was pointing out, really, what are those basic views for each procedure? And I think when we present cases at conferences, it may help for us to really be systematic in saying, rather than just showing the salient, these are some beautiful pictures that we used, but these were the views that we used to get to each step, and really going through it in more detail for everybody to start getting familiar with what the actual process looks like. And I think this statement goes a long way to show which views are used for which procedures. So I think number 1, just familiarizing yourself with that. And then also troubleshooting. If you don't have a certain view, what are your backup options? What else can you do? I think that, and then just doing cases. And I think a nice way to begin is to have TEE available for these cases and do a pilot or a period where you're using both. And therefore, in that way, you'll have both modalities available. And there's still procedures where I'm doing that routinely anyway, but I think that's a nice safeguard to then, just test the waters as you're getting better and better at ICE. And then maybe eventually you could liberate yourself from the general anesthesia and TE.
Yeah, doing the initial cases with both modalities, I agree 100%. It's very helpful. I think also starting out with easier cases and then ramping up is helpful. If you're only using ICE in your sickest patients who can't have a TEE because they have cirrhosis with esophageal varices, you're going to end up making things very difficult for yourself. Whereas if you pick some kind of straightforward, easy procedures and learn ICE on those, then when it comes to a difficult procedure, you'll be ready to go. Industry partners, the manufacturers of the ICE devices are eager to sell their devices, and so they're eager to help people learn to use them. Industry offers courses. They have simulators you can use. They'll even take you to a cadaver lab, and you can, perform ICE-guided procedures in that context. They'll also provide proctorship, and I have to say, I think that's a big piece of it. If you're doing your first ICE cases and you want, you can have somebody standing over your shoulder who has experience with them, and they can tell you, consider clocking, countering, withdraw, oh, look, what's that on the left side of your screen, that sort of thing. And that can make a big difference.
Well, I think that, when we think about the future and what is it going to look like, in the next decade, I guess I'll ask for some predictions. 10 years from now, will we be doing the majority? Do you anticipate that we'll be doing the majority of our structural procedures, at least combination of TEE and ICE, or primarily ICE? Or do you think that this is something that will take a longer time for an uptake? I think I'll start with you for that, Omar, and then I'll probably give the last word to you, Mac.
So yeah, I think we will slowly transition. As we mentioned, training is a big barrier, right? Training for thousands of people across the country. The training opportunities are there, but I think they're still limited. So they exist as the industry partners and all of those things. There are a few training courses, but I think that's going to take some time. I would also caution that the fast uptake, we need to balance patient access with expertise, because now we're handing over these procedures to interventionists and EP doctors who may or may not be echo boarded. So they're taking ownership now as the echocardiographer and also interpretation of the images. So I think we have to be a little bit careful there because because you guys are not imagers by trade, although there's a learning curve which you can obviously improve up to a very good level. So I think we have to be careful there. But I think it's a little bit of a slow runaway train, I'll call it. Because we need to treat all these patients and procedures that are very common, such as LA appendage. And the imaging quality for ICE is actually not as good as TE. However, it does have one advantage, particularly for tricuspids on the right side, and that it has something called proximity resolution, where you can get closer to the object in question, and that gives you an advantage, although the baseline imaging stats don't appear to be as good.
Yeah, I mean, I agree with Omar. I think that we have to be cautious with it because I think there's certainly cases where ICE is not adequate to at least see the complexity that you need to do the procedure. But I think part of this is also driven by the unforeseen changes in healthcare. We witnessed all of these changes in healthcare driven by the pandemic, and we're still seeing some residual of that in terms of shortages of CRNAs in the healthcare field in various parts of the country. And so I think that may be also another factor that drives institutions to use ICE even more, depending on the geographic availability of staffing that could support even the use of general anesthesia. So that's just yet another factor that institutions will have to weigh in when they look at this.
I think that's a really important point, and that you guys have all made, really, which is that there needs to be training, there needs to be collaboration with our echocardiographers. This can't just be a runaway train. And I really, want to congratulate Mac and Andy and Omar and all of your co-authors for really kind of setting the right stage and setting, the consensus of how we can do this safely to a high and to high quality, so that we can provide the best care for our patients. So congratulations on this great paper. I want to thank you guys all for joining, and thanks for tuning in to Conversations in Interventional Cardiology. See you later.